Hi, this is Dr. Mahadevan, and I am an associate professor at Stanford University. And today we're going to talk about a case of abdominal pain. So let's start. Our case is a 24-year-old female who comes in complaining of severe left lower quadrant abdominal pain and dizziness. And as noted by her picture, you can see she's holding her left lower abdomen and her forehead. Obviously, she's in a lot of pain, and she's here to try to figure out what is causing her pain. Now, whenever you evaluate a patient with an emergency complaint, the emergency medicine approach takes into account three different elements: evaluating the patient, thinking about what you found from the patient, and then acting. And though these may occur sequentially or in form of a line, evaluate, think, then act, I have depicted them here as a triangle because sometimes you need to act before you evaluate or think before you evaluate. And so sometimes we follow the sequence of evaluate, think, and act. Other times you may need to act first. So we're going to evaluate our patient with left lower quadrant pain, and that starts with the ABCs, or airway, breathing, and circulation. Her general appearance or level of consciousness is as follows. She's alert, she's pale appearing, and she's lying supine. As far as her airway is concerned, she's able to state her name without any difficulty, and she's breathing easily, and when you listen to her lung fields, you hear clear breath sounds. And finally, when we check her pulse, we find that it's very weak and that her extremities are cool to the touch. And so when we think about what's wrong on her initial evaluation, we can see there are a few things that are of concern. That would include that she is pale appearing, she has a weak radial pulse, and again, when we palpate her extremities, we find that they are cool to the touch, all concerning signs. The next thing that we're going to do in the care of this patient is get her vital signs. And as you can see, her heart rate is 130, her respiratory rate is 24, her blood pressure is 90/50, her oxygen saturation is 98%, and her temperature is 36.9 degrees Celsius. And again, of concern is her heart rate, which as you can see is elevated at 130, and her blood pressure, which is low at 90/50. And so these are two vital signs that are abnormal and are reasons for concern. So again, we're going to think as part of our initial assessment as we sum up what's wrong with this patient. She's come in with left lower quadrant pain and dizziness, and she's pale appearing. She has a weak pulse, and she's cool to the touch. And equally concerning, she has a rapid heart rate at 130, and her blood pressure is low at 90/50. So our first question in terms of thinking about this patient is this patient sick? And clearly, given her appearance, her weak pulse, the fact that she's cool, and that she has abnormal vital signs, the answer to this question is absolutely yes. She is sick or ill appearing, and that she demands our immediate attention. So when we're dealing with somebody who's ill appearing or sick and demands our immediate attention, there are several interventions that we want to think about in these very sick patients. And they are as follows: positioning the patient, controlling any active bleeding, performing cardiopulmonary resuscitation or chest compressions, defibrillating the patient if they need it, opening their airway, providing oxygen if they need oxygen or if they're really sick, assisting their ventilations with bag mask ventilation, placing the patient on a cardiac monitor, placing an IV and possibly giving the patient IV fluids, and then finally assessing their blood glucose, and if it's low, addressing it by supplementing their glucose. And so in the case of our patient who is complaining of left lower quadrant pain, is dizzy, is tachycardic, and has a low blood pressure, the immediate interventions in this particular patient are to administer oxygen, to put her on a cardiac monitor, and to start an IV, and probably in this particular case, start administering IV fluids. So again, in the emergency medicine approach, we started by evaluating, thinking, and acting, And if we think about the big picture in terms of the emergency medicine approach, once we've finished that initial evaluate, think, and act, the next step is to reevaluate the patient and see what our actions did for the patient, think again, and then act. And we keep repeating this cycle until we have gotten enough information where we can determine a final disposition for the patient. And that disposition may be the operating room, it may be the ICU, it may be admission to the hospital. In some cases, it means keeping the patient in the emergency room for a little bit longer. And in some cases, that disposition is to the patient's own home. Again, so we've started by evaluating the patient, thinking and acting. Now it's time to reevaluate the patient, think and act. And we're going to do the following. When we reevaluate, what we do is get something called the sample history, which I'm going to describe in a second, and then perform a focused or directed physical examination. The next step after that is to think, and what we think about is a differential diagnosis, which means what are all the different things that this patient might have going on? And then finally, based on the differential diagnosis, we're going to determine some diagnostic testing, what exactly we should be doing in terms of trying to figure out what the diagnosis is, and ultimately treating the patient for whatever condition that they might have, sometimes even before we have a final diagnosis. So again, as part of evaluation, we're going to get the sample history, and the sample history stands for, it's an acronym for symptoms, allergies, medications, past medical history, last meal, and events related to their chief complaint. So in this particular case, the symptoms of the patient are a 24-year-old female with severe left lower quadrant pain, and there is a mnemonic, OPQRSTU, which helps us identify additional parts of the history that can further elucidate what may be going on with the patient. So let's go through our OPQRSTU mnemonic. O stands for onset, and in this particular case, the patient's pain started 3 hours ago. It woke her from sleep, and it's worse with movement. The fact that it woke her up from sleep is concerning, and the fact that it's worse with movement makes us worry about surgical conditions. The quality is sharp, so she describes the pain as being very sharp in her left lower quadrant. Radiation means, does the pain go elsewhere? And in this particular case, she says that the pain does not radiate. On a scale of 0 to 10, she states that the pain is very severe, or 10 out of 10 being the worst possible pain, whereas 0 out of 10 would be no pain at all. And in terms of timing, she says the pain came on suddenly. So it just came on, boom, suddenly. And then finally, we look for or unifying symptoms, other symptoms that may be related to the chief complaint that bring everything together. And in this particular case, the patient tells you that she was nauseous, dizzy, and also that when asked, she's not really sure when her last menstrual period was. So there are things to worry about, and as I mentioned, anytime a patient presents with sudden or abrupt onset of abdominal pain, this often, but not always, but often indicates that they may have a serious underlying condition, things such as perforated bowel, or a bowel obstruction, or a ruptured ectopic pregnancy, or a ruptured abdominal aortic aneurysm. These are all conditions that present with sudden onset of or abrupt abdominal pain. As we move through our sample history, we note that she has no allergies, that the only medication that she's taking right now is an oral contraceptive. Her past medical history is significant for sexually transmitted infections, that her last meal was last night, and that there are no other events related to her chief complaint that she can relate to us that might help us try to figure out what's going on. When performing a focused or directed physical exam, it's obvious in a patient with abdominal pain that we're going to want to examine the abdomen. But there are 3 other parts of the body that are equally important to examine in any patient who presents with abdominal pain. And they are as follows. The back exam, so we're going to examine the back to ensure that the patient doesn't have costovertebral angle tenderness. In a male, you're going to want to do a genitourinary exam. In a female, you're going to want to do a pelvic exam. And then finally, in any patient with abdominal pain, it's advisable to do a rectal exam as well. So The focused physical exam in a patient with abdominal pain is the abdominal exam, back exam, GU or pelvic exam, and finally the rectal exam. Another warning sign is that any woman of childbearing age who has lower abdominal pain should have a pelvic exam. And the reason for this is failing to do a pelvic exam may lead you to missing a pelvic condition that could be causing the abdominal pain. Things such as pelvic inflammatory disease, a ruptured ovarian cyst, or an ectopic pregnancy can present with abdominal pain. And if you don't do a physical exam that includes a pelvic exam, you may miss one of these important conditions. So as I mentioned, we're going to do an abdominal exam, and our abdominal exam is significant for the following. She's non-distended, she has normal bowel sounds to auscultation, and on palpation, she has left lower quadrant tenderness, guarding, and rebound tenderness. So the significant findings on her physical exam are left lower quadrant tenderness, guarding, and again, rebound tenderness. Which begs the question, what is guarding? So as we look at this diagram here of a doctor palpating the abdomen of a patient, guarding occurs when you palpate someone's abdomen and their abdominal musculature contracts in response to that palpation. It's a reflexive contraction of those muscles, almost in a way to protect the patient, what's inside the patient's abdomen, from your hand. And so when you place your hand on someone's abdomen and push gently, if their abdominal musculature contracts, that is guarding. And the significance of guarding is the presence of guarding is suggestive of an acute abdomen or peritonitis or a surgical condition. This patient also has rebound. What is rebound tenderness? Well, as shown in the diagram, if you first palpate the patient's abdomen, it's usually tender when you have rebound, but that tenderness gets worse when you let go. So palpate the patient and it hurts, but when you lift your hand suddenly, the pain gets much worse. In that case, what we call this is rebound tenderness, and this finding, as well as guarding, is very suggestive of peritonitis and raises concern for a surgical condition. So again, to summarize, left lower quadrant tenderness, guarding, and rebound tenderness. But as I mentioned, it's very important to do the back, pelvic, and rectal exam. And so what we find when we do those examinations is that the patient has no costovertebral angle tenderness. She has left adnexal tenderness, but no cervical motion tenderness. And then on rectal exam, she has normal tone and no blood in her vault. The next step is to think. Think about what the possible causes of the patient's abdominal pain might be. And the way that we go about doing this is to first think about where the patient is having pain. So the location of the patient's abdominal pain can often assist with determining the differential diagnosis. And that is because certain conditions cause pain in certain regions of the abdomen. So if we think about the abdomen as having 4 quadrants, patients may have pain in their right upper quadrant, their left upper quadrant, their right lower quadrant, or their left lower quadrant, as is in the case of our patient with left lower quadrant pain. Other places that the patient may have pain are in the epigastrium, and also they may have diffuse pain that can't be localized to any specific area. So they have generalized pain, but they can't really tell you what region of their abdomen it hurts. So in our patient with left lower quadrant pain, as we think about the differential diagnosis, what are the things that we are worried about? Here is a list of different disease entities that can cause pain in the left lower quadrant in a young woman. And they include endometriosis, an incarcerated or strangulated inguinal hernia, Mittelschmerz, or the pain that you get with ovulation, ovarian torsion, pelvic inflammatory disease, regional enteritis, a ruptured abdominal aortic aneurysm, although this would be very unlikely in a young 24-year-old patient, ruptured ectopic pregnancy, a ruptured ovarian cyst, diverticulitis, and finally, ureteral calculi or kidney stones. But we know more than the fact that she just has left lower quadrant pain. We also know that on examination, she has guarding and rebound. And so, given that she has these peritoneal signs, suddenly there are a few diagnoses that jump to the top of our list. In left lower quadrant pain and peritoneal signs, we should be worried about an incarcerated inguinal hernia, ovarian torsion, a ruptured abdominal aortic aneurysm, ectopic pregnancy, a ruptured ovarian cyst, and sigmoid diverticulitis. Keep in mind that pain from an intra-abdominal condition like a gallbladder issue or ruptured spleen may not be felt in the abdomen, it may be felt outside the abdomen. So someone with biliary disease may complain of right intrascapular pain. Someone with a ruptured spleen may complain of left shoulder pain, and they may not complain specifically of abdominal pain. The corollary to this is that some extra abdominal conditions, such as pharyngitis, pneumonia, or an acute MI, can cause abdominal pain. So just because the patient is having abdominal pain, don't forget that it may be a condition that lies outside of the abdomen, like pneumonia or an acute MI. In summary, the first step in the evaluation of a patient with abdominal pain is to determine if the patient is sick, and if they are, to intervene. The next step is to get a sample history and perform a directed or focused physical exam, remembering to examine the abdomen, the back, do a pelvic or GU exam, and do a rectal exam. Keep in mind that the location of the patient's pain can help to narrow the differential diagnosis. And it's always important to focus on surgical or life-threatening causes of abdominal pain in any patient that presents with abdominal pain. Thank you very much.